So I'll focus primarily on two distinct time points where we think radiation therapy can be valuable. One is called consolidation, and that's timing after which patients with stage 4 disease have received their initial systemic therapy. It could be 3 or 4 courses. It could be up to 6 courses. They've had a good response to therapy, either stable disease or good positive response to therapy. They have limited sites of disease. And our question is, if we add radiation in those conditions at that point in time, will we allow our patients to live longer? And so, this is a complicated table. I'm just going to point some very important, highlight some very important points. Number one, multiple randomized studies, as highlighted in the red arrows, suggested that doing this approach, taking half the patients and letting them just receive systemic therapy and letting the other half get radiation at this time of consolidation, followed by continuation of systemic therapy, the patients that received the radiation to their limited metastatic sites ended up having very significant improvement in progression-free survival, or the time before which they progressed. And they also had, in 2 of the studies, an improvement in overall survival. So why did this potentially work? Because the use of radiation changed our failure pattern. No longer were these patients failing within the areas that they originally had disease because we were radiating them. They were now failing in distant sites, and they were doing so at a later point in time. So this was certainly a very exciting set of studies. One caveat is that none of these studies were in the modern era of utilizing immunotherapy. So that's what led to a larger study in the modern era of immunotherapy that was initiated back, I think, in about 2018, NRG-Lu. It was a large group of wonderful collaborators on this study, and it asked a very simple question. You have stage 4 patient at diagnosis. After you've received this first-line systemic therapy for about 4 courses, do you have oligometastatic disease? Meaning, do you have 3 or fewer sites of metastatic disease? And if so, we will randomize you to receive radiation, followed by additional systemic therapy in the form of immunotherapy or chemo, or the other half of patients, or in this case, third of patients, will receive just systemic therapy and no local therapy. So we finished randomizing 218 patients from 68 sites as part of a phase 2 portion of the study, and then did some interim analyses. At this point, it is the largest study ever looking at the role of radiation in metastatic lung cancer patients with stage 4 disease. So it really became a study that was asking the question of patients with immunotherapy, receiving immunotherapy, minus plus local, what we call LCT, local consolidative therapy. Did the patients with LCT or radiation do better? And so I wanted to highlight, just because it's not often that we do, some of the statistics and facts that we collect in one of these studies. In this case, the median age of patients was about 65. There was an equal percentage of males and females on this study. About 77% of patients were white males. Histology-wise, it's the standard distribution that we would see. About 75 to 80% of patients had non-squamous histologies, and the other had squamous. Again, I mentioned that about 90% of patients received immunotherapy. And when we looked at the number of patients with metastatic disease, or the number of metastatic sites, and remember, the eligibility requirement was 3 or fewer extracranial metastatic sites. Most patients had 1 or 2 metastatic lesions, not widespread disease. And this is the subset of patients that we wanted to show a benefit on. And we looked at, and then we did the interim analysis, and we looked at many different patient characteristics, including adverse events. And there was a slight increase in adverse events with respect to pneumonitis in the patients that received the radiation in addition to the systemic therapy. We have also done quality of life studies, which is very important in this patient population, but we haven't read those out yet. Unfortunately, the interim analysis was supposed to let us know whether we were going to go on to randomize 400 patients. But unfortunately, the benefit that was seen with LU002 with the use of radiation was limited and wasn't enough for us to proceed to the phase 3 portion of the study. And one could, make an argument, why did we not see the same breakthrough improvements in PFS and OS that we saw in the earlier, smaller randomized studies? And one aspect is that perhaps the immunotherapy in the era of immunotherapy did much better than chemotherapy, which we would expect, but so much better that it diluted the benefits that radiation would offer in this patient population. The other, and then these are still facts that we're still looking into, the toxicity, though there was a move towards an improvement with radiation therapy, the toxicity kind of diluted the benefits that the radiation was offering. So we are looking at this study, looking at other studies to try to see if we can identify a benefit. And then the last thing I would say in this consolidative phase, I would say is upfront, is that patients with EGFR inhibitors, there are multiple studies that have now looked at use of radiation upfront in this case, and they showed an overall survival benefit. So, we're still trying to figure out what the optimal timing is for the utilization of radiation therapy.